Good afternoon, everyone. Thanks for joining us. We're still admitting a few as we get going, but we'll make a start. Okay, just a few housekeeping rules before we do get going. Please keep your camera and your audio off, as most of you have already. We're very used to these Zoom meetings these days. If you've got any questions as we go through, please put them in the chat and indicate which biobank your question is for, and we'll ask them at the end. If we don't have enough time to get through all the questions, we will follow them up through email. This meeting is being recorded and we will be making it available online through our website. And at the end of the meeting, we've got a very quick anonymous feedback poll that we'll launch in Zoom. So please complete that. It's just a few multiple choice questions before you leave the session. Thank you. Okay, so myself and Alessandra are translational research facilitators. We manage Translation Manchester and the university's Wellcome Trust Translational Partnership Award. The TPA's devolved funding awarded to the university from Wellcome with the aim of increasing engagement and support for health-related translational research. And these are our four key aims: support translational research, connect across disciplines, promote innovation with industry, and facilitate a demonstrable shift in the translational research culture. We deliver the TPA through Translation Manchester, and we undertake a number of activities to achieve our aims. These include directing research support for internal and external translational funding opportunities, managing 2 translational funding schemes, which if you're interested in those, you can find out more on our website. We provide training, we hold events such as this, and we identify and overcome hurdles that researchers experience when trying to progress their research towards implementation. And access to patient samples and data is one such bottleneck, and that's why we've organised today's event. So I'll pass over to Alessandra.
Thanks, Becky. One of the hurdles that we identified is that researchers are experiencing a delay in understanding all the support facilities that are available to them because of the size of our institution. So in order to tackle this bottleneck, we established what we call the Translation Manchester Research Network, or TMRN. The TMRN is a repository, basically, of all the facilities available at the university, but also in the bigger Greater Manchester ecosystem. Those facilities are all aimed at supporting translational research and innovation at all the stages of the translational pipeline, which is pictured in this slide here. We have 50 members of the network, and the details of these partners are all collated in a useful booklet, which you can download from our website. I will also circulate the link to the booklet together with the video recording of today's session. And this is only the first of a series of events that will start again with the new year. We're hoping to organize Translation Manchester Seminar Series. Basically, this will be a monthly event, similar to this one, perhaps a bit shorter, in which all the members of the TMRN will have an opportunity to present and to explain what type of support they can provide to translational research. And we'll record all these meetings, and we'll put them on our website for the researchers to access in order to signpost them when necessary. The first meeting will be in January, and hopefully you receive information on how to register to the meeting in due course through the usual communication channels. Without further ado, I think we should then dive into the program of the day. Just to repeat a few of the housekeeping issues that Becky mentioned before, if you could keep the camera and audio off, please, have exception of the speakers, obviously. And there will be an opportunity to answer some questions at the end of the talks. So if you have any question, please can you put them in the Zoom chat so that we can read them out at the end of the event. If we don't have time to go through all the questions, we will follow those up via email. And also, as Becky mentioned earlier, we'll have a little feedback survey at the end of the event. So if you could fill that in, it's just a couple of questions before going, that would be great. And then I can stop sharing and invite our first speaker, Helen from the Manchester Allergy, Respiratory and Thoracic Surgery Biobank. You might know the bank has Manarts. Hello, Helen.
Hi, just going to try and get this on full screen. Yeah. Hi, my name's Helen Francis. Can you hear me fine?
Yeah, that's fine.
Yeah, good, thanks. I manage the Manarts Biobank, which stands for Manchester Allergy, Respiratory and Thoracic Surgery Biobank. We're based at the Northwest Lung Centre at Wythenshawe Hospital, which is part of the Manchester University Foundation Trust, or MFT. We were established in 2011, and we used to be called ManRab, but when we started collecting resected lung tissue, we were asked by the thoracic surgeons to change the name to include thoracic surgery, which is what we did. So the Northwest Lung Centre is a regional centre for respiratory disease. The unit sees patients with rare diseases, as well as those with common but complex diseases. Patients attending the clinic have numerous investigations performed as part of their clinical assessment, so there's a lot of information in the case notes, but it isn't accessible to research. We therefore set up a research tissue bank to capitalise on the clinical resource available in the regional respiratory centre. Our aim is to facilitate high quality research that's compliant with all ethical and regulatory standards, including the Human Tissue Act. We were originally supported by the Respiratory and Allergy Clinical Research Facility, but we're now self-funded. In order to build up our sample collection, we've recruited patients opportunistically when they come to clinic. We covered originally allergy, cough clinic and fungal lung disease, and then we expanded to cover other disease areas. In the start, we recruited as many patients as possible that came through the clinics, but we've moved to a more targeted approach now, focusing on areas that are research active. And during the pandemic, we've also added in acute respiratory infections so that we can recruit patients with COVID-19. A number of people have worked on the biobank in various roles since it was established, and this is the current list of staff. Professor Angela Simpson is our chief investigator. We have a laboratory manager and a database manager, and Jenny Hankinson coordinates the resected lung tissue. Our full-time recruiter post is vacant at the moment, but there's various researchers who are supporting recruitment, including staff from our R&I department and from the Manchester Clinical Research Facility. And Simon Steffen's lab team and Jay Brown's lab team are supporting the processing of the COVID samples. At the moment, we've been mainly concentrating on the COVID sample processing just because things have been very different in terms of patients coming into clinic at the moment, as you can probably appreciate. So in terms of the samples that we collect, we routinely collect blood from patients, but here's a list of the other sample types that we do collect. We've had a number of studies recently, for instance, that have needed sputum or bowel. We've also had access to resected lung tissue since 2015. In normal years, over 600 surgeries are performed at Wythenshawe Hospital for lung resection, and that's the highest number nationally. Staff from the Manchester Cancer Research Centre recruit the patients using a joint consent form, and MCRC Biobank have the cancerous tissue and we take the non-cancerous tissue. Most resected lung tissue samples are used fresh, and they're predominantly used by staff at MCCIR at the University of Manchester and the airway pharmacology team at Wythenshawe. And as I said before, Jenny Hankinson coordinates this. So in terms of recruitment, most patients we recruit opportunistically during a clinic visit. We try and collect blood samples for the biobank at the same time as any clinical samples are taken. We have multiple aliquots of serum and plasma, so there's a huge number of samples available. We can also do targeted recruitment for particular projects, especially for research that needs fresh samples. Sputum's a good example of this. The resected lung tissue is generally used in real time to extract immune cells and fibroblasts. So in terms of clinical data, we have a bespoke database which is specific to each disease area, and a lot of discussion took place with the PIs for each disease area to decide on what clinical data to capture. The data for the database is mainly the results of tests done for clinical purposes, and it's entered by Manarts staff and is taken from hospital case notes and electronic systems. This is an example of just one of the pages, which is blood test results, just to give you a feel for the huge amount of data that is available. We have something called generic ethics approval, which means that our steering committee can give ethical approval to projects providing they meet the objectives of the tissue bank. This means that they don't have to put in a full application to ethics or apply for HRA or RNI approval, which is very time consuming. We accept applications from researchers from the University of Manchester and MFT. We also accept applications from other academic institutions and commercial companies. Once we'd built up a collection of samples, we started to receive applications, and we approve about 10 a year. We've approved 98 since February 2012. Most of the applications are for large grant-funded projects, but some are used to generate pilot data for subsequent work. We've also been able to facilitate medical student, clinical fellow and PhD projects, and ManArt samples have also enabled researchers to get approval to for foundation programme projects. We were also able to contribute to a large national high impact study due to the large number of samples that we have. As we're now unfunded, we operate a cost recovery system. I can provide costs for grant applications, which would be tailored to the samples that are required. Just need to drop me an email and tell me what you need. We provide samples at a discounted rate to researchers from the University of Manchester and MFT. The costs that we have include identifying, recruiting and consenting patients, which is inherently inefficient and very time consuming. It also includes the entry of clinical data, consumables, and any processing that might be needed prior to storage. We also have to add on trust overheads, and for commercial companies, the trust will automatically add VAT. So say you wanted to apply for samples and data, what would you have to do? We have an application review process that's done by our steering committee. An application form has to be completed. It's fairly concise, it's about 8 pages long and includes questions about what you want to do and what samples and accompanying data you require. If a peer review hasn't been done already as part of a grant application, then we can arrange for one to be done. And lastly, a material transfer agreement has to be fully signed before any samples can be released for analysis. Last point to make is that I've included my email address here. So if you want any further information or you want to apply for any samples, then that's the email address to send the request to. Thanks very much for your time. That's the end. Thank you.
Thank you, Helen. That was a great talk, very informative. And if you have any question for Helen, please put them in the chat and we'll try to answer them at the end of all the talks. And next in line is Patrick Hamilton. Hello, Patrick. Are you on the line, on the call? Yes. Hello. Hi.
Yep.
Patrick
Hi.
Patrick is NIHR clinical lecturer and specialty registrar in nephrology, and he's going to tell us about the renal biobank.
Thanks, Alessandro. So I'm a clinical lecturer, but I'm also a renal registrar at the Manchester Royal Infirmary. A few years ago, we set up a renal biobank. It's for selfish reasons, essentially, so that we can do research on our patients. But we're more than happy to collaborate if people are interested. So the way renal medicine works nowadays is this hub and spoke method, where the Manchester Royal Infirmary is the tertiary centre where all of the specialists work, and then we have outlying or outreach services where we go to all the hospitals around sort of I think it's the east sector of Manchester, so it's North Manchester, Wythenshawe, Macclesfield, Stepping Hill, Trafford, Tameside and Macclesfield, which means that we cover approximately 1 million people around the Manchester area and provide renal services to them. So patients who have any renal disease will be in any of those sort of areas will be looked after by our department. It's also included the transplantation side of things, which is one of the biggest transplantation centres in the world. I think it's the biggest single centre transplantation centre in Europe, and it covers about 7 million people. So we've got access to all of those as well. And the biobank itself is located in Manchester, in the Manchester Royal Infirmary, in the Manchester Institute of Nephrology and Transplantation, which is known as MINT. And we also have access to paediatric patients so they come under the Royal Manchester Children's Hospital. So essentially, anyone who comes under our services could potentially be consented into the trial, but there are sort of caveats to that. We set this up initially trying to capture anyone, slightly pragmatically, but anyone who has an interest in kidney disease. We wanted to try and capture into the study and biobank their tissue and blood samples. So we decided that the inclusion criteria would be any child or adult who is going to have a renal biopsy, figuring out that if they've had a biopsy, then they must have something interesting going on with their kidney. So that's the inclusion criteria. It's pretty broad, basically, because most patients who end up in our services will get a biopsy at some point. And almost every transplant patient will have had a biopsy as well. So it allows for capture of those as well. And we're also allowed to take samples from healthy volunteers, adults, although we're not allowed to take biopsies from adult volunteers, which as a researcher is sometimes a bit difficult, but makes sense ethically, I think. We're allowed to collect blood, saliva, urine, and if there's any spare tissue after biopsy in the past, we're allowed to use that. And most patients will have an extra core anyway, so there's usually tissue left over. We've never had a problem with people running out of tissue if needed. And we've just had a new addition to the ethics, meaning that we can now take an extra renal biopsy tissue core specifically for research, so it doesn't have to be used for diagnostic purposes, and it can be purely used for research. So we've used that recently to do some 3D EM, which electron microscopy, which needed a special fixative. So it is quite useful. One of the things that we've noticed as we've been going along is that some patients who are on dialysis and therefore obviously have quite a dramatic kidney disease never had a biopsy in the first place, so they weren't able to be captured in this biobank. So we're now updating the ethics. We'll probably do it early next year. So anyone who's on dialysis but who hasn't had a biopsy will also be allowed to be recruited. So I suppose in general, the main diseases that would be of interest to researchers would be the autoimmune diseases, so vasculitis, things like IgAN, membranous nephropathy, quite sort of rare autoimmune diseases, but then there's also genetic diseases that affect the kidneys can be captured. Diabetic nephropathy probably won't for people on dialysis, but it's a large population base that you can get hold of samples for. As we've already been using this biobank for ourselves and for sort of internal research, essentially, we don't have a cost. So at the moment we're free, within reason, I suppose, and we're more than happy to collaborate. So if people have an interesting study which they have approval for, then more than happy for you to come and have a chat to us, and we can work out what samples that you need, and we can consent and recruit the patients, and we can also process most samples in the lab depending on what you need. If it's something weird and wonderful, then maybe you might have to do it yourselves, but we can certainly freeze down any sort of samples for you, and even do things like PBMCs if needed. If in the brochure that Alessandra and Becky have sent out, there's the contact details. Myself is probably, I'm a good one to come through to, or the other adult contact is Durga Kanigi-Churla, who is a consultant in the department. And some of you might know Professor Rachel Lennon, who works at the university, and she's a pediatric nephrologist as well. So she's the PI and head of the biobank from a pediatric point of view. So if you want samples, then just contact us, really, and we can work out a plan for you. If you need hundreds of samples, we might need to work out how to do it, because as the last person said, it can be quite time consuming consenting patients. We do have ethical approval for ongoing research. So when people consent to the biobank, they are consenting for their samples to be used for research. So we have full ethical approval, and it covers sort of most studies that you can think of. And that's about it, actually. If you have any questions, then I'm more than happy to take them now. That seems quite quick. There's not much. We're happy to collaborate, and we're keen to collaborate. So just get in touch.
Great, thanks, Patrick. That was great, and hopefully we got some new collaboration as a result of this.
Yeah, it'd be nice. Yeah. It'd be nice. We're sort of a bit insular at the moment.
You need to start from somewhere. If there is any question for Patrick, you can put them in the chat, and if we have time, we'll answer them at the end of all the other talks.
Okay, fair enough.
Good.
The next biobank is Complex Wounds at Manchester. This bank was set up by Dr. Adam Reed and Dr. Jason Wong, both senior clinical lecturers in plastic and reconstructive surgery. The Complex Wounds Biobank received a Translation Manchester Access to Expertise Award in 2020, which is currently funding a research nurse at the Manchester Foundation Trust to facilitate the collection of tissues from 200 patients over the next year. Adam has kindly sent us the slides for today, which we will go through now. The Complex Wounds at Manchester Biobank offers a non-for-profit service to researchers within the University of Manchester, other academic institutions, NHS Trusts, and private industries. The biobank aims to provide researchers with access to samples from patients with a variety of complex wounds, including but not limited to pressure ulcers, diabetic foot ulcers, venous and arterial leg ulcers, complex traumatic wounds, laterogenic wounds due to surgical complications, wounds secondary to infection, acute and chronic burn wounds, and healthy surgical wounds. Ethical approval has been granted for collection of the following types of samples from patients with complex wounds: tissue normally discarded during surgery or dressing changes, wound fluids taken as swabs, blood samples, and wound or healthy tissue biopsies. In addition to offering wound samples for biomedical researchers, the biobank team collect routine, anonymised clinical data related to the wound and patient demographics for analysis and comparison to clinical phenotypes. Routine samples are stored frozen at -80 within the MFT Biobank on the Oxford Road site. Jay Brown is the MFT Biobank Manager and will present next in this series. Fresh samples are also available on request through discussion with the Complex Wounds at Manchester team. The team also offer a responsive service that caters to specific researchers' requirements and is able to offer bespoke sample collection to meet project requirements. We strongly encourage contacting the team early on in project design to discuss feasibility, cost, timescales, and for the collection of prospective samples. The point of contact for the Complex Wounds at Manchester Biobank is Bradley Talon. Bradley is Clinical Trials Manager in the Department of Burns, Plastics and Clinical Care and can be reached with the contact details that you can see on the slide. Thanks again to Adam for sharing the slides, and now back to Ali, who will introduce our next speaker in the series.
Thanks, Becky. For the next speaker, we're staying in MFT, and I'd like to introduce you to Jay Brown, the Biobank Manager for MFT.
So this is the MFT biobanks. This is the kind of the generic biobank, I guess you'd say, for the trust. We sit in the Research and Innovation Division, and I am the Biobank Manager. So we're actually located in Clinical Sciences in the MRI. We've been established as a bank since 2009, when we were set up as part of the BRC and called the BRC Biobank. So we're currently funded through the MFT Research and Innovation Division, and we operate a cost recovery model to sort of continue to operate, as the division doesn't have all the money to support us. So we have approval from the HRA to operate as a research tissue bank, and I think Helen also mentioned this. So this means that we can release tissue for research without that research project having to have further ethical approval, which just speeds things up really. And we also have a license to store tissue from the HTA, so we're all compliant with the Human Tissue Act. So we're a small team. There's myself as the manager. Yasmin is my senior scientist slash donor coordinator slash general does everything person. And then we've got 3 lab technicians who mainly work on clinical trials, as we do a lot of clinical trial support now, as well as the tissue bank side of things. So in our bank or archive, if you want to call it that, we've got samples available from patients with a range of cancers. We are mostly a cancer bank. So we've got gynecological cancers, mostly endometrial and ovarian, quite a large collection of renal, liver cancer, colorectal is another large one, metastatic disease, which is mostly liver mets from primary colorectal cancer, and then we've got a small number of prostate cancer samples and head and neck. We also have a large collection of inflammatory bowel disease, so Crohn's and colitis, which is the main collection that we have that is non-oncology. So that was the archive. We can also do prospective collection. So this is from patients with either liver cancer, colorectal cancer, metastatic liver disease, and inflammatory bowel disease. So I've put a big disclaimer on there that due to COVID-19, all prospective collections currently suspended. So if you do need some prospective collection for your study, then by all means we can talk about this, but I can't give you a date for restarting that at the moment, as we're all full-time on COVID trials. So the sample types that we generally try to collect, but it does depend on the disease group and what's available. So if you need fresh tissue, we can often collect this on the day of surgery from pathology labs, or we can collect it and freeze it, or we do formalin fixed paraffin embedded tissue blocks. And we can also collect blood and then process to serum and plasma. So depending on the patient population and the disease group, we may be able to collect all of these subtypes from one particular patient. And also where available, we'll collect a sample of tumor tissue and a matched normal tissue from the same donor. We do have a lot of studies that aren't cancer research, but they do want basically histologically normal tissue from patients, so we can collect that. And there's the one grim picture that I put in there. It's not as good as Adam's though. So the data that we collect from our donors are the donor age, sex, height, weight, BMI, ethnicity, their medical history, what current meds they're on. We can acquire copies of the histopathology report, and then if there are any local clinical lab tests results that are available for like biochemistry and things like that, then we can request those from clinical labs. So our access policy is that we're open to all researchers, whether they're academic or private sector. So the best way to approach an application is to send an informal email to me, and we'll discuss what you need, because we don't want you filling out the application form if it's a sample type or a disease group that we just can't access because they're not on this site. So if samples are available or we can collect, then we'll progress that to a formal application, which is a brief application form which gets sent to the Access Committee for review. This will all sound very familiar, as it's basically what Helen does at Man Arts. Costs are agreed. I haven't put any costs on the slides because they do change. We do offer discounts to University of Manchester staff, and it's specific to samples and data. and then we'll have a transfer agreement signed, and then your samples will be released. And that's the end. So thank you very much. Happy to take questions at the end. I'll be around for the whole session.
Thank you, Jay. That was great. And we'll move on to our next speaker, Jane Rogan, Manchester Cancer Research Centre Biobank Manager.
Everyone see that?
Yeah, that's great. Thanks, Jane.
Great. So afternoon, everyone. So I'm Jane Rogan and I'm the business manager for the MCRC Biobank. So just by way of introduction, just to talk about how we were founded. So we've actually been established for quite a long time now, since 2007. The driver for it really was that there was a lot of disorganised sample collection within Manchester, especially around cancer. So in 2007, we set up a working group to try and work out how we could make that easier, and it was decided that we'd set up a biobank. So the MCRC was set up as a partnership. So the biobank is a partnership between the Christie, MCRC and CRUK, who's now our main funder. And it was really about organising sample collection across the region, really focusing on surgical cases from patients going for cancer surgery, and for the sample collections to be facilitated for cancer research. And the drivers for that were really around governance and legislation. So the Human Tissue Act had recently come in. To collect samples of good sample quality, we had history of samples being collected from theatres, but actually with long ischemia times or no ischemia times recorded. And then we also needed to close the loop and make sure the access to those samples was efficient. So that was really the drivers around setting up the MCRC Biobank. So how we're structured is through the Christie Research and Innovation Division. So we sit within the Innovation Division of the Trust, and that's the core sample collection team, our informatics infrastructure. So all of our data sits on the Christie servers, and the governance for the MCRC Biobank sits within the Christie as well. So we have a HTA licence and MDI on that for the Trust, as well as the Biobank, and our ethics sits under the Christie as well. But we also partner from an operational perspective with the CRUK Manchester Institute. So they've always historically been the physical home of the biobank up until the Patterson suffered a fire in 2017. And we work closely with the histology core facility. So they make our FFP blocks, they cut our sections, and they can build our TMAs as well. So they're a research core facility that support the biobanking activity. So we were set up as a pan-Manchester biobank. As I mentioned, we were set up originally as a surgical biobank. So to make sure we could collect samples from different specialties, we had to have a presence across Greater Manchester. So this just demonstrates some of the hospitals that we collect from. I would just point out at the moment that some of the collections have been paused due to COVID. But at the moment we are collecting from the Christie and from Wythenshawe Hospital as well. So we have been able to restart some of our activity, but we haven't actually been able to restart at Salford Central or at Pennine. So we are running a reduced service presently, but we have been able to continue a lot of our research programmes running out of the Christie, which has been good in light of the situation this year. So in terms of what we have stored in the biobank, so obviously because we've been going for such a long time, we have been able to build up a comprehensive biobank across most tumour types. And I would say we have a large biobank across the common tumour types. Something else that we can offer as well is linked clinical data. One of the advantages for us of having a presence at each of the trusts across Manchester is that we can link in to the different clinical databases. I think people are aware of how difficult it is to collect good quality clinical data, and actually most trusts are working on different systems and the data isn't linked. So even though it is a manual process, we are able to access patient level data at different hospitals and pull that in and link that to the samples that we collect as well. So just as an overview of what we have banked, so we've recruited nearly 20,000 patients and we have donations from around 17,000 patients. I think what's important to point out is even though for some patients we have a consent and no sample, we can access and link that consent to a sample in the pathology archive for all of the patients we have recruited. So we have the ability to pull samples in from patients that have been consented to the biobank. The biobank operates two arms. So we have the solid tumour arm, which is the bulk of our activity. So that's collecting FFP, tumour and normal. Same for frozen, and then blood, so serum, plasma and whole blood. So that's the majority of what we have banked. And then for the hematological malignancy arm, we collect and process blood and bone marrow, and that's cryopreserved, so we store viable cells. And we also store plasma and FFP tissue from trifine biopsies as well. So they all fall under the same ethical infrastructure, but they are operated slightly differently. But in terms of access, you access through the same route for both arms of the biobank. And one thing to kind of go into in a bit more detail is how we manage our biobanking strategy. So we realised quite early on that research needs to drive the sample collection, not the other way around. So as well as collecting and building up a biobank in common tumours, we realised that we needed to think about our strategy to meet researchers' needs within the region and beyond. So we now very much focus our biobanking activity on rare tumours or rare subtypes of common tumours, or what's not on here is tumours that may be more common but are quite difficult to collect. So where we don't have a large collection in some more common tumours, we will carry on banking those. But the rest of our activity is very much focused on prospective collection. So one thing that we did quite early on was facilitate prospective collection of fresh tissue. We can also do that for fluids as well. So we routinely collect acidic fluid and pleural fluid. And this supports work in culture and work with animal models as well, where we have to deliver fresh tissue or fresh fluids directly to the researcher at the point of collection. We can also support and facilitate bespoke collections. So that might be serial blood collections in oncology clinics. They're normally in collaboration with the oncologist, the medical oncologist mainly, to support collection of these samples in a variety of disease areas, but mainly driven through the Christie. And one thing we've done over recent years is support secondary biobanking activity. So this might be where researchers want support for sample collection that maps along the biobanking collection pathways. So it would make sense for our staff to also carry out that sample collection activity. Or it might be temporary storage of samples or collation of samples before they're shipped for analysis. So we have a separate application process for that. So in terms of our access, it works in a very similar way to the other biobanks in Manchester, in that we have a research tissue bank ethics approval, and that's a generic ethics approval which can confer ethics approval to users of samples. There's no need to go and get a separate ethics approval, HRA approval, or anything like that. So it's a streamlined application process. We can accept applications for bank samples or prospective collection projects. We do like researchers to come and speak to us about what they need. That then feeds into the application, which would be filled out. So that's normally after a discussion about what samples we either have stored or what we can collect prospectively. And then in terms of our pricing structure, it's competitive. So we only charge full economic costing for commercial work. The rest is subsidised. We're co-funded by CIUK. And we can provide price lists which are available on request depending on the type of work that's required. And just to go into a bit of detail about our application process, so we have two routes of application. We have a full research application, which has to be reviewed scientifically to justify release of samples. That's then ratified by an access subgroup, and we aim to have a decision within 30 working days. If people want a few samples just to do some QC or method development work, we have a different application form for that, and that is just reviewed internally. And we normally get a decision back on that within 10 working days. So quite often researchers use that as a precursor to a full research application, which is also quite useful. So we have those two routes of access. And then like the other biobanks, once the application is complete and we approve that, then there's an MTA to sign before samples are released. So in terms of accessing and who to contact, in the first instance, it's either myself or Shahzad, who's our biobank coordinator. If you could just contact us by email, then we can start those discussions about what samples you might need. And then we also have a website as well with just a bit more information, and that is being revamped in the new year as well. So there will be more information on there about how to access the biobank and the samples we might have available. Thank you.
Thank you very much, Jane. We'll move on to our next speaker, Rob Oliver, Salford Biorepository Manager and Sponsorship, Compliance and Laboratory Lead for the Research and Innovation Team in the Northern Care Alliance. Thank you, Rob.
Good afternoon, everyone. Can you see the slides firstly?
Yes, thank you.
Right, thank you. Like Jay, we're more used to Teams, which always presents a few teething problems. But so I'm here to talk about NCARC. It's not so much what we've got, it's probably more what we can do going forward. So I want to stress today, but essentially NCARC is the Northern Care Alliance Research Collection. So as we've heard numerous times, it's a tissue bank that's actually got ethical approval to release material. So we've got our own structure for doing that. Bear with me. Okay, so in terms of background, Northern Care Alliance, for some of you that may not know, it essentially covers the northern half of Greater Manchester. So it's a series of 5 hospitals representing a population of about 1 million patients, which obviously gives us a lot of potential in terms of avenues to research going forwards. The Northern Care Alliance was created in November 2018, so it's still relatively young. And the key driver for it really was to engage clinicians and patients in order to facilitate biomedical research. So what we realized is that we have a number of clinicians who would like to do some research, but actually couldn't face some of the regulatory hurdles involved with applying to ethics and that side of things. So we wanted to basically standardize the process, simplify it, and support them through that route. NCARC allows us to collect samples from any disease area. So we're not restricted to one particular field. We can essentially, in theory, approach any of the patients that step through the doors of any of our hospitals. It covers the living and adults only, so we've not included children at all, and that really is because actually they're the main majority of the patients coming through our hospitals. We can potentially include patients with impaired capacity, and potentially that could include stroke and similar conditions. In terms of samples, we try to collect surplus clinical samples, but we can also take samples that are minimally invasive. So essentially blood, urine, saliva, those sort of things we can also take. And we can, in some cases, collect samples additional to a minor procedure. For example, a muscle biopsy, we have got ethics to take a little bit of extra muscle at the stage of that biopsy that's taken place for clinical purposes. Importantly, in terms of data, we have got permission to access the full clinical records of these patients once they've consented. In the case of the Salford records, that includes digitally coded information going back over 15 years. So we have got a very powerful resource that we can tap into. The mechanisms for doing that aren't always simple, but actually the potential is huge. The consent that we've got is standardized, and we ask that any sub-collection that we have within NCARC doesn't change the consent form. We've kept it as broad as we possibly can, and we've tried to include the sort of areas that were indicated on this slide. So we've got things like standard patient information sheet. We've got retrospective and prospective access. So when a patient signs up, we can essentially access any of their material from the past and anything from the future, and that includes data as well. So again, looking at all their previous clinical history, plus how they go on to develop diseases and conditions into the future. We've got routine samples, and we can collect clinical data from all of them. We included within the consent form the ability to collect for commercial purposes and allow research to take place in other countries if needed. And this again came from experience where we've been tripped up with consent forms that have been badly designed in the past. We are allowed cost recovery, so we're not externally funded in any way, so we do rely on bringing money back in to support what we're doing. But again, we're explicit with the patients that that's what we're doing. And we can do fresh tissue approaches. So we essentially can have access to patients in surgery with the idea that we can get fresh tissue and have it in a laboratory environment within minutes or hours. And further from that, what we can also do is facilitate university researchers coming on site and perhaps doing their own preparatory work actually within our local laboratories if needed. That would take some planning to accommodate. So the 3 key areas are the collection, the storage, and the release. So collection takes place via the NCARC Collection Committee. Storage, we tend to encourage use of the Salford Biorepository facility, which I'll come back to, and release, again, is via a separate NCARC committee. So the collection committee essentially is there to manage all the sample collections that are taking place at the site. It's all operated from within research and innovation. The idea being that we don't find out about rogue collections that we didn't know were taking place. We consider applications on a monthly basis, and obviously we need to look at the importance of the research and the justification for it and whether those samples are likely to hold future value, and also consider things like the commercial or secondary value of those samples. and whether the applicant is in a position to be covering the cost of the processing and storage themselves at the outset. We can also, and importantly, we want to encourage collaborative research with all of our NCA clinicians. So we have got a lady called Natalie Garrett who can facilitate those relationships and essentially advise on who within the trust may be able to work with you as a researcher to collect a target tissue. Storage within the biorepository facility, again, I won't go into much detail here, but essentially we've got banks of freezers, all regulated equipment, the appropriate paperwork, all the necessary things that you need to run a professional modern biobank. The biorepository manager is Julie Oxton, and she can be contacted via email just for any comments about the costs. And then in terms of release, we have got the NCARC Research Access Committee, which meets on demand and considers applications via email. So we have a relatively fast turnaround for applications. We normally ask that they're pre-screened in advance just to make sure they're at a moderate standard. And then they go out and we can get decisions within a week or two, depending on the nature of the application. But again, we do ask that the cost recovery is taken into account. I'm not going to dwell for very long on the actual collections, but some of the key ones that we've got running at the moment and some of the more active ones. We've got a brain tumour collection, which Professor Roncaroli is going to talk about in 10 minutes. We've got myositis collection, we've got a lung cancer and general respiratory collection. And importantly, we've got a very active COVID-19 collection that was basically been driven by Sean Knight and has actually been very successful in collaboration with some of the other biobanks within Manchester. In terms of overall, the key points, we have defined processes and the ability to authorise research taking place. We have access to a very large patient population who's in most cases very well defined and characterised. Very generic consent, the ability to link to clinical data, the potential to use our on-site laboratories within the biomedical facility as well as the biorepository staff if needed. And we are there to drive forward collaborative relationships going into the future. We're less so just for the odd demand for the odd one or two slides. We're very much more on building relationships and actually getting our clinicians engaged in an academic environment. Overall, I'm happy to be approached about anything. I would stress that we are absolutely snowed under until the new year. We're within research and innovation. We're driving some of the vaccine studies and other work that's taking up nearly all our time. So I would say that you're unlikely to make much progress before January of next year. But there's also Natalie Garrett, who's our partnerships manager, Julie Austin, the biorepository manager, and feel free to visit our website, which does provide some of the key information that I've presented today. But that's it. So thank you very much.
Thank you, Rob. If you do have any questions for any of the speakers, please do put them in the chat and we'll get to those at the end. But we'll move on now to Andrew Robinson, Salford Royal Brain Bank Manager.
Hi everyone, my name is Andy Robinson and I'm the manager at Manchester Brain Bank. The Brain Bank is part of the University of Manchester, but it's based at Salford Royal Hospital within the Clinical Sciences building. Our current structure can be seen on the left here. The Brain Bank Director is Professor Federico Roncaroli, who is a highly regarded neuropathologist and has extensive experience in brain banking from his time at Imperial College London. I'm the manager of the Brain Bank and I'm responsible for all aspects of tissue use after donation has taken place. This includes everything from dissection to diagnostics to tissue requests from internal and external organisations. Our Brain Bank coordinator, Phil, deals with the living by consenting individuals, conducting yearly BDR assessments and liaising with families after the death of a donor to aid with brain donation. Finally, we have the technical support team, which includes James, who is funded by Brains for Dementia Research, and Yvonne, who is a part-time HEFCE-funded technician through the University of Manchester. The Brain Bank is primarily funded via the Brains for Dementia Research, or BDR initiative. With the support of Alzheimer's Society and Alzheimer's Research UK, BDR was set up in 2007 to establish a network of brain bank facilities across England and Wales, and Manchester was lucky enough to be one of them. In addition to BDR funding, we also implement the Medical Research Council, or MRC, cost recovery scheme. Until recently, the MRC provided modest funding to assist with collection of donations and neuropathologist time. However, this has now ceased, and brain banks are required to recover their cost via tariffs set centrally by the MRC. Researchers are therefore charged a small fee for use of tissue, and the monies are reinvested into brain banking. The Brain Bank was established in the late 1970s, early 1980s by Professor David Mann. Professor Mann's research interests were based in neurodegenerative disease, and therefore he set up the Brain Bank as a neurodegenerative disease brain bank. However, we have recently amended our ethical approval to allow us to collect donations from individuals with other brain diseases and disorders. So in the future, we're hoping to expand our remit to include brain donations from disorders such as brain tumours, traumatic brain injury, stroke, and epilepsy. We currently hold wet fixed FFPE blocks and slow frozen tissue from nearly 1,000 cases, although not all cases have all tissue types available. We also hold approximately 250 post-mortem cerebrospinal fluid samples from a subset of these cases. Almost all of our cases have some degree of neurodegenerative disease, and as you can see from this chart, we hold cases from a variety of different diseases. Alzheimer's disease is the most commonly represented. The Brain Bank itself is well known for its work on frontotemporal lobar degeneration, and hence we hold a large number of FTLD cases. In the others category, we hold a few cases with rarer disorders, such as multiple system atrophy, and we also hold a few cases with glioblastoma. We have varying amounts of clinical data on our cases. At death, the Brain Bank coordinator approaches the donor's GP to try and access relevant clinical notes. In addition, we hold demographics data, such as sex, age at death, etc. We also ascertain ApoE genotype, as this is important to diagnosis in neurodegenerative disease. We hold this for the majority of our cases. We also hold various markers of tissue quality, such as postmortem delay and pH of fresh tissue. Each case has a full neuropathology report from which data can be extracted for researchers to use, for example, Braak stage for Alzheimer's disease cases. For two donation streams, BDR and the CFU, we have extra data available. For the BDR stream, this can be accessed by application to the BDR Coordinating Centre. For the CFU, a collaborative approach is usually used, as data extraction from these cases can be a lengthy process. All our current samples are archived for use by prospective researchers. However, the use of these tissues is bound by the collection they belong to and the consent that was taken. For example, those consented on BDR forms are only allowed to be used in dementia research, even the normal controls. An exception to this is our existing holdings, which were collected prior to the implementation of the Human Tissue Act in 2004. We are open to discuss possible prospective collections with interested parties. However, it is important to note that there are cost implications attached to brain donations. The MRC state that taking into account the consent process and brain collection, brain dissection and preparation, tissue processing and neuropathological assessment, and linking data to brain samples, the cost of an average brain donation is approximately £2,430. To help counteract these costs, we would prefer possible collaborators to consent participants using our Brain Bank consent form. This will allow us to make brain tissue available to all researchers, not just the researcher who collected the material, and thus will allow us to recoup some of the costs via cost recovery. As a research tissue bank, Manchester Brain Bank has ethical approval to release tissue to UK research projects without the need for researchers to apply individually for ethical approval. The process starts with a tissue request form, which the requester completes, detailing their project and how they plan to use the tissue. This form is then circulated around the management committee. Requests are then approved or rejected within 2 weeks of receiving the application form. After approval, the requester's institution must complete a material transfer agreement. For researchers within the University of Manchester, we have a simplified internal transfer agreement template. For researchers outside the University of Manchester, we have a template based on the Brunswick Agreement. After all paperwork is completed, the requester is invoiced for the cost recovery of the request. I'll discuss the tariffs on the next slide. Finally, once payment is made, the Brain Bank can release the tissue for use in the requester's project. We welcome applications from all researchers, including those working within commercial entities. Manchester Brain Bank is part of the MCRC UK Brain Banks network. This was set up to harmonise brain banking in the UK. In line with the sustainable future for brain banking, the MCRC and associated charities introduced a cost recovery scheme for the provision of tissue. The tariff is standardised and has been implemented across the UK Brain Bank network. The charges for commercial users cover approximately 2/3 of the costs of retrieval, assessments and archiving of the brain tissue, whereas the charges for academic institutions cover approximately 1/3 of these costs. Not all sample types listed are available at present. Those that we can currently supply are in red. If you are intending to use human brain tissue in future projects, please remember to include these costs in any upcoming grant applications. I'm happy to discuss any inquiries relating to acquisition of tissue samples from Manchester Brain Bank. My contact details are shown here. Best practice would be to involve us as early on in the project as possible so that we can discuss options. Thank you for listening.
Thank you for that, Andy. And Andy will, I think he may even be on the call already, but he is here for the Q&A session. If you've got any questions, again, put them in the chat. We'll move to our final speaker, Professor Federico Roncaroli, Clinical Chair in Neuropathology, who will speak about the Brain Tumour Northwest Tissue Bank.
Thank you for inviting me. My job is much easier now than the governance of NCARC. We are part of it. We are actually the #1 first sub-collection in the NCARC biorepository. We are part of the new Jeffrey Jefferson Brain Research Centre, which is a joint venture between the University of Manchester and Salford Royal, well, North Carolina, probably, with the idea of promoting translational research. And the reason is that Salford is probably the biggest neuroscience centre in the UK, one of the most organised digital trusts in the UK, with a wealth of clinical data available in the electronic patient records. We are working, as you've seen, I'm the head of director of the Brain Bank and then leading on the biorepository for brain tumors, very closely with Robinson. The idea for the future is actually having a common team of biomedical scientists rotating between biorepository and Brain Bank, helping with the cutting, staining, and the tissue supply. We work very closely with Jane Rogan when it comes to metastatic brain tumors. They do have the primary. We tend to help collecting brain metastases, particularly for colorectal, renal, breast, lung, and melanoma. We don't collect any pediatric brain tumors, but we have links with the Children's Hospital in Manchester and the Children's Hospital in Liverpool. So anybody needs any issue from children and adolescents. There's been some progress recently. Dr. O'Leary, who is helping me with the technicalities of the presentation, is next door. He's now leading the liquid biopsy component of the biorepository as part of a UK consortium, which is actually part of a huge international consortium called GRASS, gliomas, the magnifying lens, with the idea of identifying biomarkers in patients with primary brain tumor. Finally, we are discussing, as we speak, a consortium with Preston and Liverpool to create a common biorepository with a common access. Quickly, most of the things we do are pretty similar to what Jane and Rob said before. Brain tumors are very rare. They are very heterogeneous. So it's important when we do collect the brain tumor that the neuropathologist is there guiding what tissue is suitable for research and what tissue is suitable for diagnosis. We have to, of course, privilege the diagnostic component. Some of the biopsies are not pretty big, talking about 1.5 centimeters, so sometimes the tissue for research is not used. But we always tend to freeze a bit of it The patients identified in the clinical meeting on a Tuesday, where we know roughly what the clinical history and the surgery would be. Then neurosurgical trainees, particularly trainees or clinical fellow, they help consenting the patients, and then alert neuropathologists and the biobank technician when the day of surgery is. And the reason is we try to minimize the time between collection in theatre and freezing. Tend to be always around, keep an eye on the tissue, and this is an example of a brain tumor where it's a pointer, where we collected part of the bulk of the tissue of the epicenter, but also at the periphery to look at the microenvironment between normal brain and neoplastic cells. Tissue comes down fresh. I do the slicing. We identify what we think is best for research, meaning no hemorrhagic components, no necrosis, and not much of normal tissue. We have quick quality check under the microscope, and then we snap freeze in liquid nitrogen, and we cryopreserve in -8. We generally embed in paraffin all the rest of the tissue. As soon as the clinical diagnosis is signed and the patient enters the clinical pathway, treatment pathway, tissue blocks become available for research. It's a huge value, not just for the histology and the chemistry. DNA is usually of excellent quality because we tend to be fixing for 24 hours max. We had quite decent RNA out of it. Not sure about protein. As said before, we now matching tissue with blood samples that we collect about 2 mL in ED for with spin for plasma and serum, and then the pellet was going to go for DNA, the DNA, but we also collected it specifically for hepatic DNA. It's a very old slide. Just to reiterate, we have 2 types of collection. One is driven by projects. If you look down, the Phenoma project is actually leading because there is quite an active group involved working on vestibular phenomena. But we are now improving. We're a bit short of staff, to be honest. But we're trying to improve and trying to collect as many patients as possible. The caveat is go to Jane for the MCRC brain bank, tissue bank, sorry. Brain tumors are not common. So we sat a couple of Zoom meetings recently with Tim Dawson from Preston and Nick Prati. They have quite a functioning brain tumor biorepository, Preston and Walton, and we decided of building a common ethics in a way that the patient is operated on in Preston and gets second surgery in Manchester and the third surgery in Liverpool. We can consent the patient once, then having primary recurrence and recurrence available for research. They do collect blood, as we do. Liverpool are also collecting CSF during, we're not prepared at the moment, very much. A bit more ambitious would be the idea of creating a common portal. It would be challenging in terms of governance, but we think it's feasible. So anybody who wants to apply for a brain tumor goes in the portal, put a query in, and he will know, or she will know in 2 seconds what is available in Manchester, Liverpool, and in Preston. Quite different from what we do for the brain bank via the Brain for Dementia Research Consortium. The queries go to the same place, and then all the 6 brain banks will know what is available and then inform the scientists. Just briefly from Preston, I've got the slide from Team. This is the 2018 slide, so the number of samples is going up. But just to reiterate, we have formalin mixed paraffin embedded tissue, frozen. They do separate cells out of primary brain tumors, and again, blood and serum. And the number of requests has gone out quite steeply in the last few years. The Walton is a broader biorepository. They have neurology samples that we don't have at the moment in Manchester, and they have a bit more in terms of imaging analytics than what we have. Very briefly, If you want to apply to NCARC, Rob said you can contact him or Natalie or Julie. But if you want to discuss a brain tumor project, I'm happy to be contacted and discuss the technicalities. As I said before, the issue is not always big. We need to privilege the clinical diagnosis, but by combining frozen and paraffin, we have been able of satisfying pretty much all the requests we had so far. Thank you.
Thank you very much, Federica. And we ran really well to time here, so we have got an opportunity for questions. We did have a few submitted during registration, so I can start with those. The first of those being, they would like to ask if you can provide plasma matched with samples, specifically livers or genotyped liver samples. So maybe one for Jay at MFT.
Yeah, so we can provide liver unmatched plasma. That's either from the archive if it's frozen, or if they need fresh, then we can look at prospective collection when we're back doing prospective collections. So we've done that in the past for many groups. So that's one of the easiest things that we can do.
That's great. So I think the attendee that asked the questions on the call. So if you want any more information, Jay's the person to contact. And say all the details for all of our speakers are in the booklet that we sent round with the Zoom link as well. Any other biobanks on livers and plasma match samples? Okay, I'll move to the next question that we had submitted. I'm trying to access FFPE samples from head and neck cancer patients who have been treated with immunotherapeutic agents and who have associated clinical outcome data. So maybe one for Jane.
Yeah, so we do have head and neck samples, but the majority available will be from surgical patients who will probably be untreated. Normally, if you would like treated samples, it would need a discussion with the clinical team, and we'll look at collection pathways for those. But it probably would be FFPE tissue rather than fresh. So I think it might be one, you know, if whoever asked that question wants to contact us offline, we can have a look at that and see whether that's something that we could do, or at least put you in touch with the clinical team.
That's great, thanks, Jane. So that would be more of a prospective collection around a clinical trial, because it's not standard of care at the moment, is it? I don't think. Yeah. So I think we just need to understand a bit more about the requirements and speak to the oncology team and see whether it's feasible. Yeah, great, thank you. So that was Jolie Ellum that asked that, so I know you know Jo, and that she'll be in touch with you around that. Anyone else got anything to add in terms of head and neck cancer patients that might have had immunotherapy?
Just to say, for MFT Biobank, we'd be in the same position as Jane in that we've got a small number of head and neck cases, but they'll have been surgical, so unlikely to have had any treatment prior to surgery.
Thank you, Jay. Okay, my next question that I had submitted. I'm interested in pancreatic cancer tumour samples, whole mount FFPE. This person's already been in contact with Jane and the MCRC bank, so they know what they've got. But does any of the other banks have pancreatic cancer tissues available?
So MFT Biobank again. So we don't have any in the bank, and Jane, so the MCRC bank through Jane collect pancreatic on this site, so we don't do that either. So if you come to me, I'll just pass it back to Jane anyway, because that's their collection.
Great, thank you, Jay. I don't know if any other banks have got anything else to add on pancreatic cancer tissues. Okay, my next question.
I would say, Becky,
sorry, Jane, go on.
No, just to come in there, it is a very difficult tumour type to collect, and the only place they do the surgeries in Manchester are at MRI, which is where we collect from. But yeah, they are quite difficult to collect, so it might be something that you'd need to look at on a more national level.
That's great. Thank you, Jane. Another question that was submitted was, how do researchers find out what data and samples are available in the biobanks? Well, hopefully today has been a start towards understanding what kind of samples each of these banks hold and the data they've got associated with them. So I think we can safely say that use the brochure that we sent round to find the contact details for the relevant bank off the back of what you've heard today, and get in touch with them and discuss what your needs are and what samples you're looking to get. And I'll move into the chat, questions that we've had in the chat. Is it possible to identify long COVID sufferers in any of the biobanks and potentially contact them to consent them to an intervention trial?
So this is Rob. I think we're probably in a good position to identify quite a lot of the COVID patients that have certainly been through Salford. I think it's a slightly difficult one, isn't it? Because there's two different issues. It's not so much for the biobank for the tissue itself, it's more for consenting into a new trial. I would probably suggest contact me, and I will probably forward your request onto Sean Knight, who might be in a better position to advise whether that's an option. So.
Thank you, Rob. Any other banks want to add anything on that question from Ken? Okay, I've got another question then in the chat. I think we may have touched on this one, the pancreatic adenocarcinoma biopsies. Yeah, so we had that as a submitted question, so we've touched on that one. Is it possible to get data associated with cardiovascular disease from any of the banks?
I'm not sure what they mean. Do they mean samples from patients with cardiovascular disease, like heart tissue, or do they mean tumor samples from patients with comorbidities? I'm not sure.
Heart tissue has come back in the chat.
Oh, right. If they contact me, years ago we had a collection of heart tissue done through the university, so we've still got that banked, which is still available. So if there's something in there that can be used, then they're welcome to apply for that.
Great, thank you, Jay. Any further questions? So we hope you've found this session useful. Again, we set this up because we know that access to samples is a bottleneck for translational researchers. This has been recorded and it will be edited by Alessandra, not by me, and made available online. So we will send the link around for you to share, and it will be on our website as a resource. If any researchers do need to contact the banks to inquire about specific samples they want to apply for, all those details are in the biobanking brochure that we sent round in the email with the Zoom link. And I think that just about brings us to a draw. So if you could just please complete the poll before you go, and we'll be sending the link round within the next week or so to this meeting. Thank you for your time.